Good evening, everyone, and thanks for joining us. We have with us Dr. Brian Hanson. Dr. Hanson graduated from the Creighton University School of Medicine, completed his postgraduate training in internal medicine and gastroenterology at the University of Minnesota, where he is now an assistant professor, fellowship site director, and director of endoscopy, as well as chief of GI at the Minneapolis VA. He's going to speak with us tonight about inadequate bowel prep, visualization, and the value of Pure-VU. Without further ado, I'd like to turn things over to Dr. Hanson.
All right. Thank you very much, Scott. And thanks, everyone, for joining. I'm really excited to give this talk, to talk about our initial experience, but really also to talk about a few things that really interest me, and that's quality in colonoscopy, and specifically in prep. And as Scott said, I've been at the Minneapolis VA. I've been here for 6 years. I'm currently the GI section chief. I've been in that role for 1 year. I am the fellowship site director for the Minneapolis VA site and also the director of endoscopy. I've held those roles for a little bit longer, 2 to 3 years. When my first interests really were Barrett's esophagus when I came on staff, radiofrequency ablation and outcomes and predicting progression from low-grade dysplasia and beyond. But that also gave me really good experience and knowledge about endoscopy and efficiency and safety and how to think about problems and new technologies. And that's really where my focus is now, is on endoscopy efficiency, safety, teaching in endoscopy, and how you do that in a productive way, maintaining a busy clinical practice. Also in anticoagulation, pre and post procedure. VA Minneapolis is a fit first institution, as is the entire VA, but we're really trying to lead that initiative for fit for screening for versus colonoscopy. We're calling it fit first. And then follow-up of those and programmatic implementation. We've added a number of process improvements over the course of the last couple of years, and new technology, and Pure-VU is just one of them. And we began our program in April, and so that's about 5 months ago or so, and we're approaching about 40 procedures. So we should be able to speak. I should be able to speak from some experience, but we can do that. I'll do that near the end of the talk, and of course, in the question and answer session. So I've entitled this talk "Poor Prep Problem: Implications, Solutions, and the Role of Intraprocedural Cleansing." And I have no financial or intellectual disclosures. This is the outline. I think we'll just talk about the problems, just get us all on the same page. I mean, we're all working gastroenterology, many of us at the VA. We have a sense of inadequate bowel prep from our experience, but let's get everybody on the same page. Then we'll talk about the importance and the impacts and implications. We'll talk about some solutions. Pure-VU is just one of those. And then we'll talk about some technical things about Pure-VU, some data, about the VA Minneapolis experience. Have a couple case examples, and then we can talk about future directions and collaboration. So inadequate bowel prep, it's defined in various ways. A good definition is in the eye of the beholder. You know it when you see it. You know a good prep. You can just say it's good. That's what your attending said. A better way is to say that it's inadequate or adequate to detect polyps greater than 6 millimeters. That's better, but not great, because that's still a little bit too much of the eye of the beholder. The best definition is one that's validated. So a validated cleanliness scale. There are more than one. The most common and the one that we use is the Boston Bowel Preparation Scale. And as an important reminder, it can never be said enough about the Boston Bowel Prep score that it's after cleansing. And I think there's important caveats around that it's operator and practice dependent. How much cleaning are you willing to do? Here are some images and definitions of Boston Bowel Prep Scale. You have the unprepared colon, which is some solid stool there. You would give a score of a 1 for a portion of mucosa can be seen, but most of the other areas cannot. A 2 for mucosa of the colon segment is well seen, with minor amounts of residual staining or small fragments of stool. And then an entirely clean colon or perfect prep gets a 3. Each of these segments, the segment of the right, left, and transverse colon, are added together to give you a total score, and that total score ranges anywhere from 0 to 9, with 6 or more being deemed adequate. So there's some patient level risk factors for poor bowel prep. We know that everyone isn't a 9. Some of those risk factors are things that I see in my practice every day. Increased age. So we see an older population at the VA. Most certainly, we do not do 50-year-old or rather 45-year-old screening colonoscopy ever. So we see an older patient population for one. Older patients have a reduced colonic transit time. That might be a result of increased comorbidities or polypharmacy. We generally see a male population at the VA. It's about 85% that way, but many days in endoscopy, we do not see any female patients. The reason that male patients don't prep as well, increased rate of comorbidities is one, and then prep adherence. Women are better at adhering to the prep for who knows various reasons, I'm sure. Then there's comorbidities, diabetes. It's the number one reason on the comorbidity scale, really why patients don't prep well. And that's in part because of what diabetes does to bowel transit time, but also people with diabetes have more comorbidities and other comorbidities that are commonly referenced as a reason for poor prep are stroke and dementia. And that probably has a lot to do with adherence or mobility or underlying chronic constipation. And then also, interestingly enough, not surprising, I'm sure, but important, very important, that socioeconomic status impacts bowel prep. It's a surrogate, is it education level, poor understanding of the process, a need for an interpreter, or Medicaid status? Lots of those things are associated with a lower socioeconomic status. But at the VA, we see an underserved and somewhat lower socioeconomic status patient. So it certainly applies to us for whatever reason the cause might be. And then there are also system level factors for poor bowel prep. So, adherence to preparation instructions, that is on the patient in some degree, but it's really on the system to create prep instructions that facilitate a good prep. Timing of prep related to procedure time. So not every facility will do a split prep, as is the next point here. And a lot of that has to do with timing of the procedure. Restraints about anesthesia, if you're using monitored anesthesia versus moderate sedation, different NPO times prior to procedure leads to different qualities of bowel prep. And of course, I think really most important is that split versus non-split. And I visited a practice not too long ago, and I was really surprised that this high-functioning practice did not do a split prep. And they don't do it for scheduling purposes. So the importance of adequate, or sometimes what I like to say is optimal prep, because adequate really stops on a Boston bowel prep of 6, and we can do better than 6 most of the time. So an adequate or optimal bowel prep leads to higher adenoma detection rate, and by extension reduces the interval colon cancer rate, because the higher the ADR, the lower the interval colon cancer rate. And it also reduces technical difficulties. This could be endoscopic torque or endoscopist torque, abdominal pressure by our ancillary staff, position changes for the patient, or just a failure to reach cecum because of a poor prep or a clogged scope, things like that. A good prep also leads to shorter exams, shorter to cecum and shorter withdrawal times, and lower perforation risks. And there's this unanswered question. I've been thinking a lot about this recently, and I don't have an answer to it. I don't think there is one in the literature. That will the patients return after an inadequate bowel prep? Essentially, are you really going to come back within 1 year? I found this abstract, and it comes with certain caveats. One, it's an abstract and it's not been peer-reviewed manuscript, so it's limited. It was presented in 2021. It reflects single center 9,000 colonoscopies performed just before the pandemic. And I think their idea was they wanted to know that in the pandemic, what was the impact of the COVID-19 pandemic on return. That might have been one angle that started them thinking. But this abstract suggests that for poor preps, that only 29% were, or 29% would not return within that same year. Or let's see, it's 29% returned in that year, and at 50% at 2 years. So, I mean, there's strong caveats that the pandemic was raging during this time and we weren't doing a lot of procedures. But let's say you forgive some forgiveness there and say that at the end of 2 years, would people have been back? Were we back to business? By and large, I think we were, and only 50% of patients at this center had returned. So like I said, there's strong caveats to this, but this is the best thing that I can find that suggests, at least to a significant degree, patients do not return in that next year. So just to stress the importance and the impact and implications here of an adequate bowel prep, like I said, it increases quality, safety, and efficiency of exam. One could say it enhances health equity, as bowel preps are more likely to be poor and lower socioeconomic status. It improves access. The less times you need to repeat a colonoscopy on a short interval, the more access you have. And as I speak to a VA audience, we all know the importance of access. It's really, truly one of our #1 measures outside of patient safety. Eliminating the risk of a repeated exam. Well, I think I've said it a few times, but it bears saying just a third or fourth time there that repeated exams are no fun for anyone, not for patients. They're a little bit demoralizing to the team and the endoscopist. They have a lot of costs for sedation and room and all the energy, caregiver expenses and all that thing. So bottom line here is that an adequate bowel preparation leads to better patient care. So there's a lot of literature about solutions and a lot of practical experience in the room tonight. From a pre-procedure perspective, a multimodal bowel prep is something we use. So we use Go Lightly plus Bisacodyl in light of the magnesium citrate recall. We use a split prep in all cases. And we do extended prep in people who have had a poor prep in the past or are going to undergo anesthesia, such that we make sure that we optimize the prep for those few and far between anesthesia cases that we are able to do. Then there's education. We have a nurse pre-call team. It's new to us in the last couple of years. They call and they review things before the prep is to begin. And that really enhances patient understanding, and they're able to emphasize the importance of a prep. A person-to-person phone call is a lot better than, say, a letter or some message they may have heard at the time of scheduling, which would have been, in some cases, months before the actual prep begins. Some centers have text message reminders to aid in reminding patients how to drink the prep. Other centers do office visits and prep classes. I know that's present in the VA. And for reimbursement and liability purposes, some of the office visit before the prep is present in other practices, but that's not something that we do. And then there's intra-procedure elements. So scope irrigation systems, simethicone, those things enhance prep, suction. And of course, kind of what we're here to talk about today, but not only that, but intra-procedural cleansing is new technology that we can use to enhance prep during a procedure. So what is Pure-VU? I had to throw in a pun, so I'm going to give you a technical overview of Pure-VU. I guess I couldn't help myself, and now that nobody's talking and I can't see anybody, I have no idea what the reactions are to a pun virtually. But this is a device. It's an over-the-scope device. I would suggest that it's similar to RFA. If you haven't seen it, we'll show a picture in a second. But there's a pliable over-the-scope attachment piece, and it looks not too dissimilar to RFA. It's loaded in a similar fashion. There is a disposable and single-use component to this, it is a disposable and single-use, the over-the-scope components. And then what's really nice is it leaves the working channel open, the scope irrigation open, and this basically your scope doesn't change, and it's functioning for the working channel, irrigation, and suction. And that's a dissimilarity to things that we know about. Variceal banding takes over your working channel, as well as the Ovesco clips for, mostly for GI bleeding. It also contains, or also part of the system is a protective oversleeve that houses the irrigation and the suction tubing. The irrigation comes with 5 jets, and the suction is a single large channel that's 3.5 times your standard colonoscope. And there's also a mobile console. So I have some pictures here of what the system looks like. if I use my mouse, Scott, are you seeing that? No, over here you probably are.
We do see it, correct.
Okay. So you see the suction channel here, much larger, 3.5 times than the suction channel of the scope. You can see that your working channel and irrigation channels are all open here. And then here are the 5 irrigation jets as part of the disposable component that goes over the scope. And here's that over the scope. I hesitate to say plastic, it's not really, it's pliable rubber-like material that goes over the scope. And then here's a picture of the mobile tower. It's really pretty low profile and moves easily in and out of rooms. All right, and then here's some images of the disposable pieces. The scope here is inserted in this. You guys aren't seeing that. I got to go over to the other screen. So let's start with here. Here is just a different view of that over the scope attachment with the suction, and then you can faintly see the water jets there. The oversleeve is this plastic sheathing, and contained within that is both the irrigation and suction. And this is when you open, in addition to the tubing, when you open up the box, this is how it's loaded. And the scope is inserted here at this end and pushed through the oversleeve, comes out here. Well, actually, it's coming in this direction, opposite direction that I stated. Here's where the scope will go through the attachment cap, and then a series of things. You pull back the sleeve and hub it up near the handle of the scope. So I was talking about irrigation. So there's a short video of the irrigation, and you see the 5 jets coming out. Here's suction. It says here smart sense suction. What this means to me is that this is pneumatic suction rather than vacuum. And so not only that, but when this port, if it were to get clogged with mucosa, it will auto purge. As opposed to when our classic suction gets clogged, we have to put a brush down, we have to spray with water or things like that to get the port clear. And then the oversleeve does allow the scope and all of its over the scope attachment to move through the colon. So I think I've said some of these things before already, but the water jet does increase water pressure. You can add simethicone into that water jet, and we do routinely for all the cases that we do to avoid the generation of bubbles. We have really great suction now here with this, especially for like little bits of solid stool or seeds or other particulates that might clog the scope. That's very frustrating and time consuming to clean the scope, and sometimes you really get a completely dysfunctional scope and you lose suction in the midst of the procedure. So that doesn't happen with the suction of the Pure-VU system because it will auto purge. In addition, if you can avoid using your scope suction, you can keep that from getting clogged. And if ever anything did happen or you were having trouble with the suction from the Pure-VU system, you have your own suction. In fact, I use both simultaneously throughout the case. Like I mentioned, it has auto purging to avoid the clog situation. And I'm sure there are a lot of questions there, and we'll get to those at the end. I'm sure it brought up a lot of questions about the system itself, but I wanted to talk about 2 studies. So let's do that. The first is from Jiminez. This study was done in Spain and Israel. This was an inpatient, this was a study of 50 patients. The mean age was 51.5 and 64% were male. This is screening, surveillance, and diagnostic studies. And Boston bowel preps during before the procedure were 5 and increased to 9 on average. Cecal intubation was 98%, and there weren't any adverse events in this first study. And then I want to contrast it a little bit with this one. Not so much, it's just a different situation. This is from Neumann et al. In 2021. This is a 94 patient study of hospitalized patients, both in the US and Germany, multiple US centers. The mean age is a little bit older here at 62. Most were men at 60%. The indications in this situation were inpatient indications, so you're not going to see screening and surveillance. You see diagnostic, basically bleeding, anemia, abdominal pain, weight loss, suspected malignancy, and diarrhea evaluations. The results here are reported by segment. So segments pre-Pure-VU were 1.41 to 1.74. After Pure-VU, 2.88 to 2.91. When you kind of add these numbers up and round them, you go from an estimated overall score of 5 to that of 9 in these cases. Fecal intubation rate was 75%. Did I say that, in the other one, it was 98%. I think that reflects the context in which it's being used here. We're in the hospital here. Fecal intubation was not necessarily clinically desired, so in 10 patients, so that left only 84, and in 71 of the 84 that they intended or needed to reach cecum, they were able to. There was one severe adverse event in this, and this was rectal perforation during an attempted retroflexion. Patient did pretty well. They did end up with a surgery of some sort, but they left the hospital within 2 days. I think other important things about these two studies is that these reflect prior generations of the system, and there's been some enhancements to them, making it a little bit perhaps easier to use and maneuver. So in this, the main outcome in these studies, it talks about Boston Bowel Prep score, and there are some limitations to that. Maybe your heads are thinking, how do they study that? Well, I'll just tell you what it is, and there are some limitations to it. But the baseline score is pre-cleaning, and the post score is after cleaning, and that's with Pure-VU in place. So this isn't a direct comparison between standard scope and not. This is what the prep was before, then doing cleaning with Pure-VU. So perhaps a quality prep could have been done in these cases had they not had Pure-VU available, but that's not what's being studied here. I think what's important to take home from this is that the bowel preps improved from suboptimal to nearly 9. And what I think is important to note is, and I was talking about adequate versus optimal. So adequate is 6 or more. That might be what you could get. It's really encouraging to see a 9, because that's really optimal. So in the inpatient setting, maybe it isn't necessary because this Boston Bowel Prep really revolves around surveillance and screening colonoscopy. But in that first study, that was mainly screening, mainly an outpatient population, and they were seeing near 9 for scores. And fecal intubation rate, especially in the outpatient setting, remains really high, 98%, well above the threshold. In the inpatient setting, I'd be interested if there were any data about the fecal intubation rate in inpatients. I don't know what the standard might be. But then again, this also was a previous generation of the device, and maybe we'll see that fecal intubation rates are higher in this 3rd generation. And then in these limited and small studies, we can say a little bit about safety, not a ton. You can't say much about 150 cases, considering a perforation rate's about maybe 1 in 10,000. So you'd have to do a lot of colonoscopies with Pure-VU in place to really know how much it might increase it. But at least in these 150, there was the one during retroflexion. So we take that for what it's worth. So other valuable outcomes that we can study, we don't have a ton of data about, is procedure length, patient tolerance, maximal surveillance intervals. Are they achieved in the context of Pure-VU? And then comparisons to historical baselines might be one way to get that pre and post Pure-VU, or in a series of cases, case match before Pure-VU, what were we able to do? And then in that case control study, compare it to studies in patients in which Pure-VU was available. And of course, I think additional safety analysis, which oftentimes comes from registries, and will just take some time to accumulate. So then I wanted to share our experience. So the Minneapolis VA is a Tier 1 facility. We have a large inpatient hospital and outpatient clinics and a spinal cord institute. We serve both an urban and rural population. Obviously, Minneapolis being our urban population, but throughout Minnesota, western Wisconsin, portions of North and South Dakota, and Nebraska also seek care here with us. And so those are most often rural patients. We have 5 endoscopy rooms. We have 5 gastroenterologists who perform endoscopy, and we have 3 surgeons, 1 general and 2 colorectal. I have a poor prep estimate in our setting of about 11%, but it's an underestimate in that it doesn't reflect the patients that don't make it back. So these are only patients for which the scope is inserted, but it's about 11%. We have had more experience, but the experience that I have and will present at ACG just includes the first 8 weeks. And the first 8 weeks and this was April and May of this year, we did 14 cases. 7 were surveillance and 7 were diagnostic. Most were done under moderate sedation. Our Boston Bowel Prep score before was 4.2, which is really similar to the other studies, but ranged from 0 to 9. We did do some cases in patients whose bowel prep was essentially perfect. And that was because we got a history that it might be bad, and it turns out it was really good. And that tells you a little bit about how the fallibility of trying to predict a prep. And then we did a case or two to gain experience for which we didn't have a great suspicion that the bowel prep was poor, but maybe the patient had a history of poor bowel prep, something like that. It just turns out they did a much better job this time. And then we increased that Boston Bowel Prep score to 8.6, or a range of 8 to 9. So everybody achieved a adequate prep and nearing optimal when you get to the 8 to 9 range, or ideal, maybe one could say. Our cecal intubation rate during these 14 cases was 85% if you looked at all of them. However, 2 of the cases failed, but they failed really before the Pure-VU was instituted. It was clear from the provider's experience and the procedure notes that the patients were not going to tolerate moderate sedation, and that was really the problem. Maybe we wouldn't have gotten to seek him in those cases, but the procedures were failing before Pure-VU was instituted. So we learned a little bit from that experience. If patients aren't tolerating a standard colonoscope, they're probably not going to tolerate well when you add Pure-VU, because you didn't make it easier. You might have made it a little bit more difficult. These were, in all cases where there was surveillance, we gave maximal follow-up, and that makes sense, right? Because our range of 8 to 9 of Boston Bowel Prep score after Pure-VU would suggest that the preps were adequate. We should be giving them the maximum amount. The average procedure time was 48 minutes, longer than our historical class measure of about 30, but no adverse events. Again, 14 cases, no adverse events. Doesn't say too much. But what I do want to point out here, and I'm really excited to analyze our data to see where we've gone in this regard. But this is procedure duration over time. And this is just for one provider. We are finding that there's a learning curve. And in the 14 cases, one provider did 9, and then one provider did about each of the others. So they had 1 or 2 procedures under their belt versus 9. So when we looked just in the first 2 months and 9 cases done by one provider, we saw procedure times go down. And it seemed to be following a good trend there. Something also caught in procedure time that's a little bit complicated is if we use this as a primary versus a rescue. So if we use Pure-VU as primary, there's no setup time included in the procedure time. If we use it as rescue, so to speak, we look inside and find out the prep is bad and we can't clean it with the regular, we want to move to Pure-VU, then that time of setup adds. And we will get faster and better with that setup, but it's included in these first cases for sure. In further analysis, we'll have enough cases that we can really report primary versus rescue separately so that we can tease out that procedure, the additional time taken to set up the device. Okay, all right. Well, we might normally entertain questions, but we'll hold them to the end, and I'll just give you 2 case studies to show you what this looks like in real practice. So the first is a 73-year-old male patient with diabetes on anticoagulation who presents with positive FIT. This is really a classic case for us. His last bowel movement was brown. We used Pure-VU primarily here because of his risk factors, his anticoagulation status, his brown stool. We really wanted to get this procedure done today. We use moderate sedation for 99% of the cases, or EGDs and colons that we do. He got 3 and 100. It's pretty standard for us. We usually start with 2 and 50, so he didn't get very much for sedation. The insertion time was for almost 5 minutes, and withdrawal was 18. For a total procedure time of 23, we found 5 polyps, 2 to 5 millimeters in range, and the baseline bowel prep went from 4 to 9. And because of this, and they were all adenomas, we gave him a 3-year surveillance. And here's a video. It's about a minute long. I'll talk over it a bit. but we're in cecum here. And that clearly was like a 1 here. There's no solid stool, but you can hardly see any mucosa. And this is that sticky stuff that you can't get off the wall very easily, especially with classic irrigation, or if your irrigation is suboptimal to begin with, it can be very difficult to peel this stuff off the mucosa. With the 5 jets and the vortex and the irrigation, you really get a vigorous washing that really lifts this thick stuff off the walls. And this guy might have drank the prep right. He may never prep adequately if this is the kind of residual he has after he drinks everything that he's supposed to. He's on anticoagulation, so if we do a procedure another day, we're gonna have to hold it another day. So that's suboptimal, in particular, to have to keep people off of anticoagulation for longer than they really need to be. And there's about 10 or 15 seconds. Well, that's the end of the video there. So a pretty good job. Not perfect. This was, but probably a 2, and definitely big enough to see the polyps that we're most interested in. All right, and so then study number 2, very kind of similar patient, 74-year-old. This guy is on chronic opiates. He has constipation as a result. He's presenting with weight loss, abdominal pain, and worsening constipation. He didn't split his prep, and he didn't drink at all. His last bowel movement was light tan. We used Pure-VU primarily because of the risk factors again, because in this case, we're using monitored anesthesia care, so we don't want to waste any time. And we definitely don't want to waste this slot because we don't have very many of them. The insertion time was pretty long. This guy had a really difficult colon. It took 43 minutes to get to the end. It took 18 minutes to withdraw, and I'll show you why. And maybe you'll be impressed that it took 18 minutes only to withdraw. Their findings were that it was a normal colon. He's 74, so his Boston bowel prep was 4 to 8, meaning it was adequate. That means no further colon cancer screening. So I think this was a really great utilization of the spot, and would have invested a lot of resources to try to bring him back, all for not finding anything significant, but it means he doesn't have to have another colonoscopy. I don't have video here, but you can see the cecum on the left. I'll start circling here, and then this is what it looked like afterwards. Cecum is really behind the valve here, but you get the idea. And then this is what the hepatic flexure looked like. The sigmoid colon was a better prep to begin with. I don't have a pre-picture there. But essentially, we 8 or 9 was our end here in the Boston bowel prep, and really did this particular gentleman a good service. So I've been thinking about an algorithm, and as I was preparing for this talk, I was like, this is exactly a good opportunity to put the algorithm that I've been thinking about together. Well, I don't know how much we need an algorithm with a series of if-thens and yes-nos and risk factors, but I think any patient with a poor prep is a candidate for Pure-VU, especially those with non-modifiable risk factors for a poor prep. You can't fix their diabetes, you can't take away their dementia, their Parkinson, their spinal cord injury. If they didn't prep well this time and they drank it all, there's no way that they're ever going to be any better. Patients with a long drive time, they've invested a lot, their drivers invested a lot to get here. They may not show up. We're going to try to figure out who doesn't show up for when there's inadequate preps, and see if we can further identify those risk factors for loss to follow-up. Maybe distance is one of them. Anticoagulation status, if patient has to hold their anticoagulation once, they're going to have to hold it again. So if we can't get the procedure done today, we've now instilled 2 holds. We have limited anesthesia. We have every VA, every center nationwide has limited access. Demand outstrips availability. So anesthesia needs is one really good reason here at the Minneapolis VA, but any spot's important to us. Just the monitored anesthesia and general anesthesia spots are just even more precious. So we want to think about it in all of those cases. And we also give ourselves more time for those cases, so it's very unlikely to disrupt our flow by adding procedural time for these anesthesia cases. So we should use it in those, certainly. There are some exclusions, anatomical issues. If you can't get through the sigmoid with the scope without Pure-VU on it, you're not going to get through with it. If somebody has severe colitis, perhaps the irrigation would cause too much bleeding and trauma, but that you don't really need Pure-VU for that, because you don't need an adequate prep when you're dealing with severe colitis. You just need enough to make the diagnosis and take the biopsies. So here's some lessons from our initial experience. Identifying inadequate prep by effluent was difficult for us. We didn't try very hard, but in our anecdotal experience, it didn't help. Sometimes we heard stories about how brown the stool is, how it had solid pieces of lettuce in it, and then we got a perfect prep without any washing. So we're looking now more globally, looking for more than one risk factor. So non-adherence, a risk factor for poor prep in the past are all evidence. And we take that all into account if to get a good gestalt of who's going to need it and who it might be worth setting up primarily versus waiting for rescue use. My suggestion is just use it. Trying to find perfect patients is difficult. It impedes staff and endoscopist learning curve because there is one for the setup and there is one for the endoscopist doing the procedure. And accept that hindsight will be 20/20. So I tried to be really judicious, find the right cases, not waste any product, and make sure that we didn't add time to cases unnecessarily. That became perfect became at a cost of progress. So we're not achieving perfection in identifying patients, especially when you're first using this system, because it's really important to get consolidated good experience for your staff and for your endoscopists. And I've also changed my thinking a little bit. I was just a greater than 6, good enough. Well, good enough. I mean, for every point in increase in Boston Bowel Prep score, you see more adenomas, and for every adenoma or every percent increase in adenomas you detect, you reduce colon cancer incidence in the interval. So optimal prep, great prep, perfect prep, excellent prep. I'll call it optimal, not just adequate. So that was on my learning curve here. And then remember the overall cost metrics. There are lots of things to consider, and they're somewhat hard to quantify, but inpatient stays, missed opportunities, clinic access, these are all really good reasons to use it. Here's some tips and tricks. Anticipated increase of sedation needs. So we've seen that patients need a little bit more medicine, and since we do moderate sedation, that means fentanyl and Versed. I've started to preemptively use diphenhydramine. The procedure times are a little bit longer in cases. I haven't seen Benadryl harm anybody, so we're using it preemptively for Pure-VU cases. Primary use versus rescue use. So if it wasn't clear and I just made these terms up, what I deem primary use is when you load the Pure-VU before the case starts based on your intent to use it. And rescue is you've inserted the scope, you've discovered a poor prep, and then you take the scope out and reload it. When using rescue use, it helps if the physician and the tech set up the scope. So in our room, I should say, we have a physician, a tech, and a nurse. So myself, we're the endoscopist, and the tech set up the scope, and RN sets up the console, and we usually have a runner out there to bring all the stuff to us. So I think 2 people setting up the scope is ideal. There's things to hold, lubrication to apply, things of that nature. And then one person, the RN in our case, can usually set up the console, or it could be the runner, it could be anybody. But I think that's the team that works best in rescue so that you can apply the device promptly and not waste any time. I'm seeing that it takes like 5 minutes, 10 at most. 10 is like if we're really struggling. I would say it's much less than 5 minutes, or more often it's less than 5 minutes than more. We work to identify patients in the pre-procedure check-in. It helps for the primary use of it, getting things set up. We only have one Pure-VU system for 5 rooms. That's enough for us at this point in time, but it's good to just kind of get your ducks in a row so that you're not looking for the disposable, and that you have the machine and the water and the simethicone all ready to go. Speaking of simethicone, we typically add 5 mLs to a liter. I don't know where we came up with it, but that's what we do. I'm finding that that might be a little bit much, that 2.5 is fine. You get a little bit of gray, and we are sending in a lot of volume here. So a gray solution in 60 ml aliquots to flush from the irrigation channel is not much to obscure. But if you get a liter of liquid in there, you'd like to be able to see through some of it, so you didn't have to suction all of it. Our staff like a solidifying agent, so that when you have the suction canister, that you're not carrying around a few liters of liquid for the chance that it might spill or make a huge mess. So we add a solidifying agent so that if it were to spill during transport, it wouldn't make much of a mess at all. And then I would advise teams and endoscopy centers to identify an MD super user, a core team of people in the initial rollout and trial period. just because there's a learning curve to setting it up, and it takes a few practice. And you set it up with Jeff or one of the reps. That's easy outside the patient situation, but then you kind of add the pressure of the endoscopy suite and staying on time, and a bunch of people trying to help all at once rather than an expert guiding you through the process. It takes a little bit. Just like over the scope clips, just like a bander, these things are not easy for the brand new tech. And so I think a super user really helps in this situation. I'm going to close with take-home points. So adequate and optimal bowel prep is important. Remember, it enhances quality, efficiency, and ultimately patient outcomes. Bowel prep is the responsibility of any high reliable organization. I mean, this is how we feel. It's not the patient, it is us. The patient can only do so much. Yeah, there's a few patients who didn't take responsibility for it, but it's our responsibility to help them take responsibility. So all of the things that I mentioned that we do and that the institution should do are really important. We should never blame the patient for poor bowel prep. And we shouldn't even blame the risk factors. Blaming is just kind of a bad thing to do around prep, I think. We should take ownership of it. There are patient and system level factors then that prevent optimal bowel prep in select patients. So again, taking ownership over those elements. There's a key role for intraprocedural bowel cleansing. That's what we spent like the last 25 minutes talking about, but it by no means replaces all the other measures to get the bowel prep to begin with. So this is not a silver bullet. This does not replace split preps. This does not replace pre-calls or any of the other things that we do to get most of our patients in good shape. And quality and cost metrics are somewhat difficult to capture and quantify. I talked about a lot of them. We talk a lot about them every day around here in endoscopy, even outside of this. But placing patients first is central to that analysis. And if we just focus on that, a lot of this other stuff follows. Future directions, we're going to continue to collect data. We have now 40 cases completed. We're assessing our internal bowel prep quality and measuring adherence for that 1-year follow-up. Will patients come back after a poor prep? So how important from that single perspective is it to get a clean colon during the initial procedure? We're looking towards large multi-center data for Pure-VU. I think it's necessary, and we'd like to be a part of it. We hope you would too. And we'll be at ACG here this year to present our initial experiences.
Dr. Hanson, I just want to thank you again. Super informative, very helpful. I hope everybody enjoyed it as much as I did.
Thank you, everybody, for your attendance. And send me an email, text me, Teams me, hit me up on Twitter. Thanks, everybody.